the day. And everybody's getting a little giddy. And if you had been in the Judiciary Committee that I was just in, you'd even be more giddy. Yeah, it's like watching paint dry on the wall. Sometimes. So, okay, where's the list? Where's my schedule right there? Okay, let's see. Okay, let's go with H.R. 640, Representative Broderick. Whatever you want to do. Pardon? That's good. It's always polite. It's always polite to stand up. That now, don't assume anything. You know what assuming does. Besides, I think this is his first time to present something in front of this committee. So officially now, the health and this meeting of the Human Health and Services Committee is officially open.
Okay, there we go. Is it on?
Yeah.
All right. Madam Chair, thank you, and members of the committee. In your green folder, you've got a original copy, but we've had to bring a substitute. You should have a copy of LC 336179S, which is a redraft today. The original resolution called for a joint House-Senate study committee, and we redrafted it just for a House study committee and with fewer members. And the subject of the committee is to look at the mechanics and value of school-based health centers throughout the state, which we've got, I understand, some 50-something throughout the state now, and how these can be structured as far as not only physical health for children, but also mental health, utilizing either public health or other nurses actually on the school campus for these children. There are a lot of benefits for that, and I've contended that we've got a trained workforce in this state through our public health system that we need to utilize. And these clinics that are in existence are providing a lot of benefits. It was one of the recommendations of the Rural Hospital Stabilization Study Committee to look at school-based health clinics, that we can cut down on emergency room visits and also provide a education source for children. And I think we could find a lot of benefit with it. And I have learned from the CMOs that they will actually reimburse a school nurse for an encounter fee. So it could be, if we could figure out a way to do that, if the child is Peach Care Medicaid eligible, that they'll actually reimburse for a school nurse for an encounter fee with these children. That could be a possible revenue source for the school system to help to supplement their school nurse program. I know some systems will use the state money with their school nurses and then supplement to bring additional funds in so they can have more nurses to cover more schools. So I think there would be some benefit from this, and not only from, again, acute health, but also the mental health aspect, that you've got a trained and trusted individual in the school that children could come to, not only for their health care, but also education. If we look at chronic disease, asthma, any other number of conditions. My daughter was home this weekend. She's out in Arkansas doing a residency in dietetics, and her assignment last week was to screen 800 Head Start children on BMI. 19% were overweight, 19% were obese, and these are Head Start age, preschool age. So, you know, there are a lot of conditions that we could utilize that clinic nurse as both a caregiver and an educator. And I think did they pass out, there was a background sheet on this?
They did.
Okay. I'll be glad to answer any questions. And again, I think there's just some benefit. Like I say, we've got a trained workforce in this state, and let's utilize those. There's also the telemedicine component that could be incorporated into a school-based health clinic.
Okay. You ready for questions from the committee?
Yeah.
Okay. A word to the wise. This makes it to the floor for a vote. I would suggest that you not talk about obese children and BMIs and testing and so forth. If anybody was here, do we remember the discussion about
Exactly.
that's left up to families and that we shouldn't embarrass the poor children? It, might
Exactly,
hurt their
understand.
feelings if
Okay.
word went home to their parents that they were obese or so forth, and the child would be
Exactly.
intimidated.
Okay. Thank you. Thank
You're
you
welcome.
for the word of advice.
Representative Reinders.
Thank you, Madam Chair, and thank you for bringing this very important piece of legislation. I just want to call to the committee's attention, as well as the author of this particular resolution. We've got, I think, 3 of them on the calendar today, and the only thing that I saw in advance was there's no limit to the number of meetings. It's not uncommon for us to somehow put a potential limit to that. I know you wouldn't abuse it or whatever the case may be, but
No.
just thinking in the big picture of things, I didn't know what was appropriate, but I do know that in the past there has been some limits on the number of meetings that we have, and my friend Representative Kidd and the ones I've served on in the past, it seems to me that jog my mind and memory is kind of like 5 meetings or 7, something like that, and I just so
I think it would be a limited number. I know there's a cost involved because you're going to there's going to be the per diems involved with it, but
Right.
A limited number, and I think it may be some site visits, but also looking at some other background material in order to make an effective report from the committee.
Representative Reinders, would, on line 59, the fact that the committee would be paid for no more than 5 days unless additional days were approved, would that?
I think that does satisfy
That does
it.
satisfy
When
your
you look under
question.
the headings of the meetings, it had maybe called on, I think, the 5 for per diem. I think that's fair.
That takes care of
Thank you.
Okay. Representative Pruitt.
Thank you, Madam Chair. And this is just an observation or suggestion. Would you please do what you can to make sure that some people from South Georgia, I always say rural, I forget that there's rural up above Atlanta, but down below the Macon area are recognized and maybe a part of the study committee. Thank you.
Certainly.
And Representative Pruitt, I will tell you, if there's going to be site visits in South Georgia, they're some of the best examples of the school-based health programs in the
I
state.
think Albany is a shining example.
That one's been. You've been there?
Yeah, that's a good job.
Okay. Other questions from the committee? Okay, now we have people that want to speak on the bill. Rick Ward, if you'll come to the podium and tell people who you're with.
Thank you, Madam Chair. My name is Rick Ward. I'm with the Georgia chapter of the American Academy of Pediatrics. That's the professional association of the state's over 2,800 pediatricians, and we come in support of the resolution and thank the author for bringing this issue to your attention. It seems quite intuitive to us that there's a connection between education and health that is strong and certainly causative in many instances, so it certainly deserves to be studied, and school-based health clinics where they exist have proven to be wonderful adjuncts to health care for children and pediatric care, so we're very much in support of this, Madam Chair.
Thank you. Shia Ross.
Good afternoon, Madam Chair. My name is Shay Ross. I'm from Georgia Partnership for Telehealth, and we just wanted to say that we are in support of this resolution as well. We manage 58 telehealth school clinics in the state already that are very successful, and we are happy that the legislature is taking this up and the House is looking at this, and hopefully a study committee. So we just want to be a resource and considered, telemedicine considered during this process as well. So thank you. We are in support, and if there are any questions about telemedicine throughout this process, we'd like to be a part of that. So, thank you.
Where's in the metro area? Where's one of your best examples of it being used?
We work with Whiteford Clinic.
Where?
Whiteford Clinic. It is actually pretty close to where we are now, off of Hosea Williams Drive. So we are working with them with 2 metro schools this upcoming fall. We also have schools in North Georgia, South Georgia. So
I mean, the reason I was asking if the committee ever wanted to go on a field trip, I was just wondering where there was
Sure.
one close by that we could visit.
We're in Fayetteville as well. That's it's about 40 minutes outside the city. So
That's not close to the Capitol. If you want members to come, we have to be close.
okay. We will make sure that we have a good close.
Is there any
school for you.
questions for Ms. Ross? No. Thank
Thank you so much.
Erica Sitkoff and Polly McKinney.
Hello, thank you for considering this bill. I'm Polly McKinney. I'm with Voices for Georgia's Children, and we wholly support this resolution. We'd love to see a study committee on school-based health. I'm going to let Erica do our, the brainy part of this presentation, and I am just going to read the committee. Georgia Partnership for Excellence in Education could not be here today because they were all tied up in other meetings, but they did send an email saying that they wanted the committee to know that they, too, supported a study committee on school-based health and mental health. And then Christy Kay, who's the president of Health Empowers, also sent us an email wanting us to alert the committee that that they too support this resolution. So, without further ado, I'll let Erica make us look good.
Thank you, Polly. Thank you, Madam Chairman. Thank you, Representative Broderick. Voices works very closely with the School-Based Health Alliance as well as Representative Broderick. As Polly said, we're a child policy and advocacy organization that works on child health issues. That includes mental health as well. My background as a child psychologist who's worked in education for the past decade, I've seen how when we look at the child as a whole, health as well as education, it works. Children can't learn if they're not healthy, they're not present, they're not connected with the school emotionally and socially, and there isn't hope. And in 2013, when the youth behavior risk surveillance came out, we found that nearly a third of Georgia's teens don't have hope, and they experience hopelessness throughout the school year. School-based health centers require startup costs to be initiated as well as sustainability. Currently in Georgia, 100% of our school-based health centers are startup costs funded through private foundations. Nationally, though, that's typically divided up through state funds as well as local government funds. And health insurance reimbursement is how they're sustained, Medicaid primarily. And in fact, in Georgia, schools are allowed to and able to bill for some of the administrative costs that come with supporting school-based health centers, except for that's rarely used currently. And our hopes is that the school-based health center committee will help us find ways that we can better support schools to sustain. Not only nationally, but also in Georgia, our school-based health centers have demonstrated effectiveness. They've reduced emergency room visits and hospitalizations for children with asthma, so again, helping them be present at school. They've reduced the cost of pediatric care for Medicaid and Peach Care, on average by 50% in the Whiteford Clinic that Shay just spoke of. They improve school attendance in the school-based health center at Lake Forest. 50% of the students referred return to class. So again, keeping kids in school. They increase child wellness checks, decrease prescription drug use, and decrease costs for transportation. So overall, you can see their academic as well as health and cost benefits. With that, if there are any questions, we're happy to answer them. We also have additional supplemental information that we can provide to the committee for further data and support.
Are there any questions for Ms. Sitkoff? No questions. Thank you very much.
Thank you very much.
Is that it? That's it. Okay, that's and all the people that we have signed up to speak on this resolution. Are any other further questions from the committee? All right, I have a motion to pass. Do I hear a second? A motion to pass and second. Any other further discussion? Okay, everyone in favor of the passage of the supplement to House Resolution 640, say aye. Anyone opposed, say no. Okay, the ayes have it. Thank you.
Thank you, Madam Chair, and thank you, committee, and we'll come up with a positive report.
Good things for the rest of our schools in our state. Okay. Representative Dempsey. Which bill is it? That's what? 641. House Resolution 641.
Thank you, Madam Chairman, members of the committee. We brought this to you as a substitute because just like Representative Broderick, we had hoped to possibly get this out as a joint study committee, and the clock kind of caught us on that measure. So this will create the House Study Committee on Children's Mental Health to deal with early intervention and prevention of mental health problems in children and adolescents, resulting in, we think, some better statistics, some better early intervention, and hopefully it will save lives and help children realize new pathways and those who also touch their lives in any way. This is broader than just the school-based clinic, while there could also be some intersection at times in that conversation, because I would certainly hope that school-based clinics could help with this as well. This deals only with mental health. The funding is different for that, and for some time we perhaps have not done quite as much as we could have because we were not able to. So it's time to readdress that and look at those resources that possibly we can identify to deliver services there. It has come with conversation of the Department of Behavioral Health and Developmental Disabilities. It has come from advocates who basically have asked for this some time and have seen the disparity there. And if we do not address it early, it can often become a much bigger problem later. If there are any questions, I'll be glad to try to address them.
Representative Kidd.
Very brief question. Thank you, ma'am, for bringing this forward. Do you think it'd be beneficial to have one of these for adults also?
Is that starting with the members of the General Assembly?
Yes, ma'am.
Especially at this time of year?
Be a candidate for sure, I think, because we're all kind of busy.
Did I hear you say that? That they'd have to start in the Senate? Well, it is a smaller body. Right. Okay. We no other questions from the committee. We have people that want to speak on this one. Ellen Yeager. Hang on. She's so short you couldn't see her.
I'll wave. Thank you, Madam Chair. Thank you, Representative Dempsey. You've just been wonderful on mental health issues. We so appreciate it. There is really no other illness that from first symptoms to diagnosis and treatment is an average of 10 years. That's a very, very long time for someone to progress in an illness before it's treated. Kids are really scattered throughout the system. There is no system for mental health for children. They're in the Department of Behavioral Health, they're in the Department of Community Health, they're in the Department of Juvenile Justice and the education system. The money goes lots of places, but it's not coordinated. We don't see these kids in a more holistic way, and we really have to do that. So the money really has to be put into early intervention and prevention. That's key. It is not different than any other illness in that if you treat it early, you identify it, you're going to get a better outcome. That's really crucial. I know that you heard about suicide from another bill, but I will remind you the youngest child in Georgia who took their life was 8. I know we can do better than that. I really do. So please help us. This is a wonderful opportunity to look at children's mental health, and thank you.
Thank you. Are there questions? Ms. Yeager? Thank you. Erica Sitcott, are you going to, Ms. McKinney, you going to send her back up again to do the work?
That's all right. We partner very well together. Hi, everyone, again. Really quickly, just to piggyback actually off of what Ellen just eloquently said. Mental Health America's 2015 report on the state of mental health in America indicates that 8% of Georgia's children and adolescents have a serious emotional disorder. And while 8% might not seem like a large number on the surface, what that means in Georgia is 91,000 children. Furthermore, they said approximately 85,000 children have an unmet mental health need. So we have the need. We haven't figured out the best way to meet that need yet, and I think that this study committee will help us do that. Thank you.
Questions? None? Thank you. Rick Ward?
Well, this is easy, saying amen to the choir. I just would like to second Ellen's comments, and pediatricians certainly would be supportive of this. I think they see it in so many different ways, that mental health services for children are probably the most under-resourced aspect of all our health care in the state for kids. We don't have enough trained child psychologists, child psychiatrists, clinical social workers, all the number of specialties that could assist these children when they have mental health problems. And they land in a general pediatrician's office, and they do the best they can. They can refer to what's in their area, but there simply isn't enough. So this is one area that certainly deserves more study. We can do better, as someone just said.
Okay.
Thank you, Madam Chair.
Oh, wait a minute, we have a question? Representative Petrie.
Yeah, just a brief comment and then a question. I wanted to ask Representative Dempsey, first of all, this speaks to mental health problems in children. So we will not be looking at, in this study committee, individuals with developmental disabilities. So when you think about individuals with autism, et cetera, that would be beyond the purview of this committee, correct?
It would be.
Okay. Just
I
wanted
will
to make
tell
sure.
you that there is another study committee that's making its way through higher education that deals with post-secondary opportunities, particularly for developmental disabilities, work and education.
Gotcha. And of course, I'm interested in that because there's SB1 on the other side. We've talked about the autism bill and how much can be done by early intervention with autism. But at any rate, just wanted to clarify that. Then all I would say then is that having been in human services for 25 years, I have to tell you, if there's one area that is we are lacking the most in, it is in mental health services in our community. So I appreciate your work.
Thank you. And if we wait long enough, pretty soon they'll say in House Bill 1 that it also cures developmental disabilities and autism. It seems to have grown quite a lot with everything that it can cure or help. Okay, from the committee, let's see. Okay, we have a do pass and a second. Any further comments from the committee or questions? Okay, hearing none. Everyone in favor of the passage of the substitute to House Resolution 641, say aye. Anyone opposed? No. The ayes have it. Thank you, Representative.
Thank you.
Okay, since I have a House resolution also, I'll call 612. You want to do this?
Sure.
You ready?
Good, Madam Chairman, we're glad to recognize you for your
My
resolution, House Bill 612.
Okay, guys, we're talking about female parts, so just batten down the hatches for a minute. This came to me because of a group of very concerned young women professionals, and they brought it to me based on the fact that many young women are putting off pregnancy until they have their careers established and they're in their late 30s or early 40s. And many are running into the problems of having uterine fibroids, which are interfering or creating a problem where they cannot get pregnant. This does happen to both Caucasians, but it is very prevalent in African American females. And it is an area that has been greatly understudied. Not only does it cause a problem with pregnancies and the lack of being able to get pregnant and establish families, as many women want to do later in life, but it also can really incapacitate women as far as their ability to work and how they feel, causing many symptoms, and especially because of pain. And because of the dedication of these young women that are so committed to learning more about the illness, educating the public about it, and just making people generally aware and finding out what we might do in the future to help alleviate this problem, they asked me to put in the study committee, and that's what House Resolution 612 does. Here again, it is limited, Representative Reinders, to up to 5 days unless additional days are approved by the Speaker. I'll be glad to take any questions.
Thank you, Madam Chairman. Have anyone with a question for Madam Chairman? Number 12.
Drenner. Representative Drenner.
Representative Drenner.
Thank you. Madam Chair, what's the White Dress Project?
Representative Brenner, what happens to one of the problems with uterine fibroids is there can be excessive bleeding, and it causes a problem for young women that have this problem being able to wear white dresses. So they decided to call their campaign the White Dress Campaign. Thank you for that question.
Anybody else have an interesting question?
I mean, I get all the interesting bills, lactation bills, HIV bills, just, bring them on.
Do we have anyone speaking on the bill?
No, I'm really sort of hurt that no one is here to speak on the bill, but I will tell you the young ladies, the young women that brought this to my attention are both professionals and are at work. So
We'd be glad to entertain a motion at this time. Good motion to do pass. All those in favor? Aye. Thank you. And those opposed? No. You've got it, Madam Chair.
Thank you very much for that. Let's see what we're doing now. Senator Huffstetler, let's go with Senate Bill 114. 114.
Thank you, Chair Cooper. This bill, Senate Bill 114, I hope is a simple bill that won't cause too many questions, but a while back, if you look on line 19 of that bill, the community service boards had been under Department of Health, and they were moved out, and so this is just a cleanup. It lists those that don't follow, that can have a nurse protocol agreement with more than 4 advanced practice registered nurses. Lines 15 through 22 are those. Now, originally, line 19 there, the Community Service Board, was encompassed up above, and since they've been broken out, we just need to have the language that reiterates that they still can enter into this with more than 4.
Okay.
That's the essence of this bill. It's barely over a page long. Chuck Clay is here to testify if you need him to, but if you don't, I'm sure he'll be glad not to.
Well, questions for the senator, but first, I think, is this your first time to come to Health and Human Services?
It is.
In the House? Well, obviously you weren't trained as a House member, because the first thing we tell young legislators not to do is ever say it's just a simple bill. That can cause you more trouble than you would ever know. Let's hope that's not the case here.
I'll remember that.
Okay, do we have questions for the senator? Nope. We have no questions for the senator. Okay, and we have no one that wants to speak in the bill. Boy, you are lucky. Okay, motion, you entertain a motion? Okay, we have a motion for due pass. Do I hear a second? Okay, any further discussion from the committee? No? So everyone in the favor of the passage of Senate Bill 114, say aye. And anyone opposed, say no. Okay, the ayes have it, Senator.
All right.
You lucked out this time.
I believe you've agreed to carry this bill on the House floor.
I will do it.
All right. If I could take 5 more seconds, and there is a Morehouse School of Medicine fellowship person, if you want to stand up, Gigi, follow me around, that's a clinical psychologist. So if you hear that a psychologist is following me around and evaluate me, I want to make sure I clear that up.
Are there about 55 more of you somewhere that we can attach to each and every senator so they can have each have their same one?
We probably deserve that. Thank you very much.
You opened it up with saying she was attached to you. I'm just expanding it. We would never think that about our senators. Goodness gracious. They'd probably say lots worse things. What was that? Okay. All right. Senator Dugan, Senate Bill 131.
Thank you, Madam Chair. This is a extremely complicated agency bill.
I got it.
I may be new, but I am trainable.
Now, you do realize the message you carry back across the hall is that we really love our senators.
As long as we have our psychologist with us. all this is changing the verbiage within the DBHDD's crisis stabilization units from licensure to certification. Now, what I want to make sure that everybody understands, that has nothing to do to impact the care of the patients in the facilities. All it does is provide an easier, let me give you an example. Right now, if you want to change a door from a 36-inch wide door to a 39-inch wide door for ADA capacity, you have to convene a board. This streamlines the process. Subject to your questions.
Okay. Are there questions for the senator? Representative Kidd.
Not really a question, but at the proper time, I'd like to offer an amendment.
And I take that as a friendly amendment.
Okay.
I hope so.
Representative Reinders.
Thank you, Madam Chair, and welcome, Senator. I just want to make sure that I get for the record that there will be no changes in fees, no changes in curriculum, and what license versus it is nothing more than a word change. There's no other change we'll hear about down the road.
You have my assurances.
Thank you.
Representative Petrie.
Senator, would this pertain also to community-based crisis units like we have with Benchmark now that contracts with DBHDD as well?
I had to look back over my shoulder for a second because what I wanted to clarify, the 26 crisis stabilization units are my understanding this all this applies to, and I got a confirmation over my left shoulder.
Okay, this would not relate then to those facilities. Thank you.
I mean, these are the units, correct me, Senator, these are the units that have been set up across our state to be not the first responders to somebody but where they can, if somebody needs temporary hospitalization or care under supervised, they can be taken on a short-term basis. Is that correct? We're getting Andrew over there with the is okaying everything. Okay. 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 Representative Kidd.
In addition to the amendment, I have to offer a couple of brief questions, if I may. Currently, it has to go through basically it'll be a licensure, the licensure division to be licensed as other facilities have to be licensed to do the similar thing. Is that correct? Yes, that's correct.
Andrew, I think you better come up and
come on up.
Testify and answer these questions. Identify yourself and.
Madam Chair, members of the committee, Andrew Johnson with the Department of Behavioral Health and Developmental Disabilities. Currently, the only facilities that we license whatsoever are the 26 crisis stabilization units. That was a change in recent years. What we're doing is when we switch from licensure to certification, currently that licensure and changes that are made go through the whole rules and regs process with our boards, so a 9-day process. When we switch that, we don't switch whatsoever. Our staff who do the licensure process and the oversight process, none of those folks, none of that process is changing whatsoever. What we're doing is to make ourselves, to move things along a little bit quicker every time we want to change one small detail, not to have to go through the 90-day rulemaking process.
All right. So that's my second question as far as the rulemaking process. Currently, the rulemaking process has to be submitted to the chair lady, any proposed rules and so forth, and disseminated to the members of the committee or whatever else. Are you now bypassing that process so nobody knows what you're going to be doing until after it's done?
So the amendment.
Representative Kidd, do you have an amendment you would like to clean that up?
Yes, sir. Whenever she wants me to read it.
Okay. I think now would be a good time.
Yes, ma'am.
And the amendment, wait a minute, the amendment, does everybody have the amendment in their?
Doesn't have an LC on it. Do you have
okay, who am I going to fuss at now that's going to bring me an amendment and they don't bring enough copies for my committee?
Chuck, you should be ashamed. No LC on it. Yeah, the LC 213668. That's it.
Okay. Do we have, no. Okay. We're going to stand down, on this bill for a few minutes. Can you give a copy of that to Andrew? And Andrew, you go beg Bori or whatever you have to do to get enough copies for the committee. Thank you, Senator. You can, and we'll go on to another bill.
Thank you, Madam Chair. I was kidding when I said it was a really complicated bill, but
maybe the process is complicated on how you get an amendment on. Okay. Okay, let's go to 194. Senate Bill 194, Senator Jeffries.
Thank you, Madam Chair, committee members. I brought Elizabeth Stoll up here with me because if there's a complicated question, I'm going to need her help. But on Senate Bill 194, what it does is it makes manufacturers that make home dialysis equipment and devices, it lets them ship them straight to the patient's house, and it exempts them from the pharmacy and the DMV registration, and that's all it does.
Okay. Questions for the senator? Okay. Representative Harden.
Thank you, Madam Chair. Senator, I was wondering what provisions of Chapter 26-4-6 are being exempted?
Can I have one? Here.
Already, a pharmacy can ship drug directly to a patient. There's no problem with that. So, what are we exempting from the chapter?
Hi, I'm Elizabeth Stoll with Baxter Healthcare.
I'm sorry, I can't hear.
Okay.
Yeah, thanks.
Hi, Elizabeth Stoll with Baxter Healthcare. Basically, it would exempt manufacturing companies that create peritoneal and home hemodialysis equipment and supplies and pharmacy and DMEs that ship directly from their manufacturing site to the patient's home from having to be a full licensed pharmacy.
And not being a full licensed pharmacist, what provisions of the law do you not have to abide by?
They don't have to have a full pharmacy in our distribution site in Buford, which means they don't have to have a compounding station, they don't have to have scales, they don't have to have a sink, the things that we would never, we already have a prescription label on the box that's never been opened from our site in North Carolina. You don't have to create a second pharmacy label to stick onto the box that's identical to the one that's already there. There's just a bunch of compliance issues when you have to be a full licensed pharmacy that this would exempt just the manufacturers of just these products, of just these patients, no one else. Also, just to make a side note, there are lots of states that already do this. Texas, Virginia, Colorado, Oklahoma, Ohio, Pennsylvania, California.
And they passed laws to exempt.
Yes, they have either regulations or laws that do this exact thing.
All right, and this probably could be done by regulation. I hesitate to put into law something that exempts one particular product, and then maybe there would be another particular product that comes along when this could be handled by regulations. Have you contacted the pharmacy board to see if you could get?
Yes, we have contacted them, and they had they have not contacted us back about the legislation.
Now, when did you contact them?
A month ago? When the bill was introduced. January. In January.
All right. What I was wondering, I think it can be handled by regulation, and I would rather see it done than for us to start making exemptions in law for specific products. And Baxter is a great company. Don't get me wrong. I'm all for them. They're very reputable. But I'm afraid we might be setting a precedent here that would not be in the best interest of, we do have to do a lot to control illegal drug distribution and understanding this is one product. But I really would prefer that y'all do this by, you can be exempted from certain regulations, and that's what you want, and that's done all the time. I would set up an appointment with the board and get them to exempt, but that's just my opinion. But thank you very much.
Thank you.
Okay, Representative Broadwick.
Okay, thank you, Madam Chair. All right, I want to make sure I'm familiar with the peritoneal dialysis products, and these products are Legend or prescription-only products. They are.
The solutions are, yes.
Okay, and they are being dispensed by a licensed pharmacist.
Yes.
In the state of Georgia.
Yes.
Okay, so that pharmacist is going to be would be required to adhere to the rules and regulations of the pharmacy laws in the state of Georgia. But you're actually, what you're requesting is that your facility has exemptions as far as some of the requirements, like you say, for compounding, sink, these other things that are safety issues that are part of the pharmacy statute. Is that your request is that it's actually a facility exemption rather than total
what would the
exemption?
alternative be?
Total exemption from the Pharmacy Practice Act.
I'm trying to see if I understand what the division of the question is exactly.
All right. If, like Representative Harden indicated, by board regulation, if you could have exemption from certain requirements for, quote, a pharmacy, because that's what you're operating as, is a pharmacy.
It's a distribution site. It's not, they don't produce, or I'm sorry, they do not distribute any other pharmaceutical products outside of the dialysate. And there's nothing else that would be going through there that would go to the patient's home that would be considered a Legend drug. So while technically, yes, there are waivers and things that you can do from a facility standpoint, from a registration standpoint, it's the entire code section of having to comply with all of the regulations of the Pharmacy Practice Act for the distribution of those products that are sealed in Marion, North Carolina, and shipped directly to Beaufort and directly from Beaufort to someone's home. And we're talking about, 13 boxes that weigh 50 pounds each that come from, that go, I mean, it's not like anything that you would see in a CVS. It's not anything that you would have that would be something that would be done in a conflicting manner, in the sense of like counterfeit drugs. There's not, I mean, nobody is trying to make money off of.
There's no abuse potential.
Yeah, no abuse. That's another
with
point. There's no compounding involved with this. It's direct from the manufacturing site, put into a box, label on the box. The prescriptions go through Illinois, which is a licensed pharmacy. They put the label on there. It goes to Beaufort, and the drivers that are employed by us pick them up and take them directly to the patient's home and stack them for them to be able to use their products every month.
I understand that, but but you're saying that your facility would not be licensed or regulated by the state of Georgia. Is that correct?
It would be regulated under FDA requirements.
Okay.
And it would be, I mean, it's regulated by lots more than just the Board of Pharmacy. I mean, there's lots of regulatory agencies that oversee that operation from beginning to end. But it would not be considered, it would be like a limited license is what they have in some of these states. And it's not a full pharmacy license is what it would become. Because they don't process any other prescriptions for patients in that manner.
But under the pharmacy laws and rules of the state, we are charged with the protection of the safety and health and well-being of the patients of the state of Georgia.
Correct.
So I think maybe a special license might be a better way to go than just a complete exemption from the Practice Act. You've got a nuclear pharmacy license. You've got other specialty licenses that the board could approve.
We don't do nuclear pharmacy. I don't think there is a
No,
special
but I'm talking about
pharmacy
the ability
license.
to have a specialty license. You've got a retail license. You've got a hospital license. You've got a nuclear pharmacy license.
So you're saying that we should create a new license for
your type of practice, yes, ma'am.
Okay.
Okay.
Because that's what it is. It is a specialty practice. No further questions. Thank you, Madam Chair.
Representative Broadwick, this almost seems like this is an out-of-state. We have out-of-state pharmacies shipping medicine into the state of Georgia, this seems to me that this is very similar to out-of-state meds being sent in. Yeah. Okay. Representative Drenner. Hmm? No. Well. You waved? I'm sorry. Representative Barr.
Thank you, Senator. The question I have, if we pass this, full confidence, patients safe, will they receive their materials quicker? And will then, in turn, we're cutting out part of the process, will it be cheaper? So those are my two questions.
For the second part of your question, yes, it will definitely lower the cost of our distribution model. Absolutely. It doesn't just help Baxter. There's other companies such as Fresenius Medical Supply that also manufactures these products and ships. I don't want to speak for them, but I'm assuming it would help them as well. And the first part of your question again?
Will then I receive my product quicker?
Yes, because it wouldn't have to go through all the various steps that are required at the Buford location at this point, so that potentially could be faster, yes.
Thank you.
Okay, Representative Reinders.
Thank you. Representative Barr just was going down the path that I wanted to go down. I mean, has Baxter been damaged because of the way Georgia's done it for decades?
When you say damaged and...
Well, I mean, have you been harmed?
I'm not sure I follow what...
I mean, if everything's fine, then why do you want to fix it?
Because
there's a financial reason?
It does cause extra financial burden as well as... and I guess it kind of plays off your question as well. I mean, any time that you have to go through additional steps of a process, it lengthens the time of those process steps. I can get more information if necessary on exactly from our supply chain, exactly what those steps would be.
I'm a little worried about opening up a window that others may want to go through in the future. And since I've never almost heard of this for decades, I'm sitting there going, how much damage can there be? And if that's the right word. And finally, do you feel patient safety is enhanced by us passing this, or have we been hurting Georgians because we didn't have this before?
I do not think in any way that the current law harms patients, but I definitely know that patients in other states where they don't require this are not being harmed, and Georgia's are safer because you do have the requirement. I mean, I guess by default, that's why we're asking to have it removed, as we do not believe that it is a necessary process step in our supply chain to guarantee the safety and efficacy of our products to those patients. For instance, as I mentioned, in many other states, large states, mind you, they conform exactly to this law that we're asking to change, and those patients are safe every day.
All right. Thank you.
Okay, let me ask a question before we go to Representative Pruitt. Now, we're talking about patients with end-stage renal disease. Really sick people.
For the most part, the people that are treated at home tend to be actually a little more healthy. They have better outcomes and are treated at night, so they actually can go to work and school in the day if they so choose, versus the people that go to in-center dialysis. They spend 3 days a week in the center and don't feel so good after their treatments on the every off day when they come home.
Okay, so it's direct shipment with more convenience to the patient that has this end-stage renal disease, which will be fatal, correct, if they don't receive a kidney transplant at some point.
Absolutely.
So that they can do the dialysis in the home. So
yes.
Okay, that's my question. Representative Pruitt.
Thank you, Madam Chair. And to follow up on that question, can they do dialysis at home without this service that you're offering?
You mean without the equipment being shipped to their home? No.
So you're actually shipping I thought it was just supplies, but you're shipping all the equipment to their home.
Well, they get an automated peritoneal dialysis machine for the most part. Some people actually do it by gravity. You don't have to have a machine. They have a port inside their stomach that uses their peritoneum, which is the lining inside your stomach, to actually act as a filter or kidney per se. So you put put these bags of solution into the stomach, and they dwell for a while, and then you drain them out, put some in, you drain it out, and it goes on for so many hours. And basically, it removes all the toxins from your body. And so there is a machine that can heat the product and make it go in and out as you sleep so that you don't have to physically do the exchanges yourself. The machine does it for you. But you can do it by, I mean, you could be in a car by yourself and hang it up and do your dialysis by yourself as well through peritoneum. But yes, you have to have the supplies sent to your home. You have to have tubing, which is a DME. You have to have different components monthly that are sent to your house for you to be able to do this.
2 quick follow-ups, if you don't mind. One would be, do you have to have somebody train these people, or is it self-explanatory?
They are associated with a dialysis facility that you might be familiar with, like an FMC or a DaVita or an independent, a DCI. I think they have those in Georgia.
All right. And lastly, is there any other type of medication or equipment or supplies that falls under the same category that this has been done for in the past? This process, this step.
In Georgia?
This step removal.
Oh, I'm not
yes,
sure.
in Georgia.
I'm not sure about that. You're saying about other products that don't qualify under the home dialysis and ESRD portfolio. I don't know the answer to that.
So this is the first time we know of that anybody's been this path to try to, okay. Thank you, Madam Chair.
I'm not sure.
Okay. How would a patient, what happens now? Where do they get, where do they get these supplies?
It's the same process. It's just removing the licensure requirement and the pharmacy setup requirement that's used in our distribution site in Buford.
Okay.
So it would alleviate us having to be in compliance with all of the regulations to be a full functioning pharmacy.
Like to have
like
a
right now,
compounding
we technically could do anything we wanted to as it relates to a pharmacy, but we don't. And we're a manufacturing company. We don't have pharmacy operations except for to distribute this product to the patient's home. And if there was an alternative way to, if we could send it to a CVS for them, but there's no way with the volume and the,
we're talking about, for the committee members, we're talking about bags of solution about this size that weigh how much? Probably
5-10 pounds.
And multiple of these used.
In a box, yeah.
In a box.
And they'll get I don't know how many boxes, but it's like 1,000 pounds. It's a lot of equipment and product, and you can't just go pick it up in your car at Buford. It definitely needs full pallet truckloads and very strong people to move them into someone's home.
Okay. Representative Kidd.
Yes, ma'am. I was hoping somebody else was going to ask this question, but I might know the answer. But the bill basically, as you indicated earlier, deals with end-stage renal disease. End-stage renal disease. On line 14, why we're adding the word optometrist?
What? There's another bill riding with it. Representative Kidd, you've heard about bills that ride?
I never heard about that before, no ma'am.
Yeah. Somebody was to ride along with it, so, okay.
Christmas trees before, but
No, Representative Beverly?
I think I can answer, thanks, Madam Chair. I think I can answer your question, Representative. No, I won't do that. I have a question about the supply line. Why is a pharmacist included currently? And removing the pharmacist, that gives an opportunity for the patient to receive the medication quicker. But why currently is a pharmacist in a part of the regulatory
Because
supply?
the products that we're distributing are considered pharmaceutical products by the FDA, and they're, as he asked, they're called legend drugs, which means you actually have to have a prescription written by a licensed practitioner to write pharmacy prescriptions. And so these boxes contain something that would be considered a pharmaceutical product, and that's why the pharmacist under Georgia law is required. Under other states, they don't necessarily require it for this type of distribution of this product.
Quick follow-up question. So in essence, a prescribing physician could prescribe this treatment regimen, this end-stage renal, and then once they get that prescription, it goes to the manufacturer. You guys are distributing place,
Correct.
and y'all would just distribute it directly to the patient
Correct.
under a prescription that was already authorized by a licensed practitioner.
Correct.
Under current law, pharmacists have to sign off on it because it's a regulation when you dispense this particular product to a patient They have to be a part of the supply chain from
Correct.
a structural standpoint,
Correct.
but not necessarily to help train the patient or to authorize that this is the way to do it.
No,
It's just a part of the regulatory process.
Correct.
Okay.
Yes.
Representative Drenner.
Just to follow up on what Representative Beverly just said. So doesn't it seems to me that how can a regulation exempt someone from the law? You know, if we went through this through a regulatory process, wouldn't we have to change the law first in order for this to be okay?
Seems like it to me.
I think so.
I would. Who? Representative Harden.
All right, thank you, Madam Chair. And I don't want to prolong this, but are you saying that you will not have pharmacists involved in the shipping of the product? Is that what you're saying?
No, there are pharmacists.
Well, I thought that's what your answer to Dr.
No,
Beverly was.
There's pharmacists that receive. There's a licensed pharmacy in Illinois, in our headquarters, that actually receive the prescriptions and process the prescriptions from there. And then the product leaves from our North Carolina facility and goes to Buford on a Baxter truck. It sits in this facility and waits for the Illinois pharmacy to call and say, we have a script for patient X in this amount on this level of product. Please send it to their home. They set up the delivery truck's loaded, and they ship it to the home.
I know you're saying Illinois pharmacy, so you're shipping this from out of state.
No, it never goes to Illinois. This prescription goes to Illinois.
Okay, all right. All right, well, and so what I'm trying to see is why this would create any problem at all in the supply chain. The only thing you, as I see you're asking for here, is exemption from, as you mentioned, having to have compound. You don't have to have in all pharmacies. You can get these exemptions for a specialty pharmacy, as Representative Broderick has said, and I would be willing to offer to help you with that issue if you'd like. I have a reluctance to create an exemption in law that might want to be followed by other people distributing dangerous or drugs. So thank you very much, Madam Chair.
Right. Representative Harden, I think the Baxter attorneys and all have looked at this very carefully in the laws of the state of Georgia, and they feel like, changing the law is the way to go, and that's why they have come at it this way, that is the most efficient and correct way to do rather than going through the rule regulations. Representative Pack. Do you hear?
I'm sorry, I walked in late on the presentation.
I know where you've been. That wonderful Judiciary Committee that was going on.
We're passing some bills, apparently.
Yeah.
I know it's probably, having this bill would make it cheaper for Baxter to provide service. The question becomes, on the states that you are allowed to do this, has the price of the dilate dropped for the consumer? And if so, how much?
95% of the people who have ESRD are on Medicare. It's the only condition when the program was created in 1965 that actually creates a subset of coverage for people based on diagnosis. So almost everyone that has ESRD qualifies for Medicare. There's a few people on the beginning of treatment that are still covered by their private insurer, as well as by either Medicaid or self-pay. But what happens is when you go onto home dialysis, you automatically get transferred out of your primary insurance, whether it's Medicaid or private insurance, to Medicare immediately. So the Medicare reimbursement rate is set in statute as to how much they reimburse for this therapy. So it is a bundled rate that's already negotiated with the providers and the treatment centers. So ours is just a negotiation with those treatment centers. And just to note that this therapy is an advantage to Medicaid for the state of Georgia, because anyone that goes on it automatically moves over to Medicare primary immediately, even if they're 2 years old or 14 years old or 55 years old. So it's a positive there. But from a financial standpoint, I don't think the answer to your question would be that it would lower the cost to the consumer.
So there's no private pay individuals that
There are
get
private
covered?
pay individuals,
So
but
what would be the cost drop for those folks?
In the state of Georgia, as it relates to
No, what I mean is, by passing the exemption, it allows you to bypass what's considered to be an overhead in terms of shipping it to a pharmacist.
Mhm.
Question I have is, the savings that you get, is that passed along to the consumer, or is that eaten up as a profit for Baxter?
we don't get direct pay from insurers. We sell our product and contract with these providers, which would be like a DaVita or the nephrologist for their payment or whatever it is. So we don't get payment from those entities for our products.
But Representative Pack, as you heard, anyone with end-stage renal disease that goes on dialysis, even if they had private insurance, are very quickly transferred over, right?
For home dialysis,
Right.
yes, but I do believe the wait period for private pay is still in effect. It's for Medicaid. So Medicare will allow those Medicaid patients to go Medicare primary immediately.
Okay.
That makes sense. It's complicated.
Okay. So the majority would be over. There's very few that can afford the long-term cost of dialysis.
Yeah, the wait period I think is like 30 months for private pay on home. Don't quote me on this. And 33 for in-center for private pay to switch.
To do it. Okay. Got it. Okay. Are there any more questions from the committee? I don't think we have anyone signed up to speak. Okay. What's the pleasure of the committee? Somebody move. Representative Pruitt?
I'll waive.
Okay. Representative Randall?
Madam Chair, I move to pass substitute SB 194, LC 336160.
Okay. We have a motion to do pass and a second. Is there further discussion? Okay. For whatever the committee's consideration, I will tell you, and I'm not sure that Baxter's aware of this, that dealing with the pharmacy board can be very difficult. And I think Representative Hardin would agree with that. He had to help us when the pharmacy board kept changing the rules and almost shut down our methadone clinics. And I appreciate the fact, remember that, Representative Hardin? He had to intercede and help us with that. Still, when we had to go to certified special kind of prescription pads when we had narcotics, I'm not sure that the pharmacy board has ever come up with the seal that they wanted to put on those things, and it was delayed for months and months and months.
On that was not the pharmacy board. That was the legislators that put that seal in the law that they had to do it, and they didn't want to do it. It was a problem. But I do feel like I have seen exemptions from the type of regulations that you have to have compounding, you have to have this, and you have to have that. So, and as specialty pharmacies like Representative Broderick has said, I do feel we could very easily get them out of the situation they want to be out of without putting what I feel like is a dangerous thing in our law.
Okay. Okay, so we have a motion that we do pass and a second for that. Any further discussion? Okay, everyone in favor of, wait a minute. Representative Rogers, did you?
Yeah, Madam Chair, I just want to make sure I understand what we're doing. I hear the pharmacists here on the committee concerned, but if I have renal failure and I go to a doctor, my doctor, he writes a prescription, I don't go to my local pharmacy, correct?
That's right.
Okay.
You wouldn't do that now.
Okay.
The only difference would be is that we would be allowing Baxter, like an out-of-state pharmacy like we have, be able to ship it in, but that still would be a physician's prescription handled by a pharmacy in Illinois, and then they would ship it in. They just wouldn't have to have on-site at the Baxter plant or their distribution ship like a full-blown pharmacy, or go to the pharmacy board and try to go through the rigors of trying to get an exception to the bill.
And I heard her say that most of these patients are on Medicare or Medicaid. You know what I heard you say?
Medicare.
Medicare. Okay.
Representative Reinders.
You know, I think when I've listened to the testimony today, I think what I hear is that the safety of the public hasn't been jeopardized one way or the other. But it streamlines Baxter's efficiencies.
Correct.
That we couldn't give testimony that says actually benefits the patient. But you know what? We are up here about increasing efficiencies. I mean, we do want to be as effective and as efficient as we can be in both the public and in the private sector. And I'm a little concerned about this hole we may be opening to allow others to go through it. But I think this is the right thing to do. I think we have the right as legislators to reserve in the future someone else that wants to drive through this type of exemption. And I don't see anything wrong with trying to increase efficiencies, because I haven't heard anywhere where the public is harmed by this. So I think it's a good bill, and I'm going to support it.
Before we have a final vote, after all that discussion on the major part of the bill, there is a rider on this bill. People need to check it out. It is on the back. If you'll remember, we passed out of this committee a bill that would allow optometrists and ophthalmologists to, okay refills, and for a pharmacist to refill a prescription for an eye drop when 70% of that had been used because of patients being shaky and not getting the drops in their eyes. When they were doing this, they also realized in the part of the law, and there is one addition to it that you'll find on line 44, where they needed to go back in and say practitioner instead of prescriber. And did we correct the other part of it? And made that change. So it's on line 44. It's on the back. And also on lines, I had to find where it was, on lines 13 in the Pharmacy Act, on lines 14, when that was passed, optometrists did not order medications. They now order and are given permission to order a limited type of prescriptions, and so the word optometrist needed to be added in to clarify that. So that was the changes in the law. Are there any questions on that part? Yeah. Dr. Beverly? I mean, are there any questions? Dr. Beverly can answer them for you or anything. So what the CHOCUS rule, he's not going to vote on it because of the CHOCUS rule. That doesn't work in committee, Dr. Beverly. So now, given that explanation, since we didn't bypass what's writing with the bill, we have a motion do pass and a second. Everyone, any more discussion? Everyone in favor of the passage of the substitute to Senate Bill 194, say aye. Aye. Anyone opposed? No. No. Okay. The ayes have it. Thank you.
Thank you, Madam Chair. I'm glad I could answer all y'all's questions.
Pardon?
Told you I had her for a reason.
You may not get as much help next time. Okay, Senator Dugan, you're back, and we all have copies of that amendment you have. Okay, Representative Kidd.
Madam Chair, forgive me for causing this to be extended as any longer than it needed to be. Before the representative gets going, background on this. I got this amendment early this afternoon. I chose not to do a substitute and bring it to you because I didn't want y'all to think as a committee that I was sliding something in after it had passed out of the Senate. That's my bad. Next time I'll just let y'all think I've slipped something in. No.
Oh, no, we would have pointed it out.
But the...
Madam Chair, he's got a bill in front of my committee 2 days from now. You don't want to slip in anything on him, do we?
I don't know. Let me see.
It wouldn't be the first time, Representative. But you see in front of you the language that the good representative is going to submit. Do you want to talk it?
You can't get a light going out, everybody got it. And I apologize for the committee not having it, but the lobbyist was supposed to get it. Next time I'll make sure I do it myself.
And poor Andrew, and I know his daddy. I guess I'll have to call his daddy when he gets home.
It was somebody else.
Well, since I'm the one up here presenting, I think that's probably my responsibility. I'll take the hit on that one.
If you'd like me to read it, you have it in front of everybody sees it, so they don't know that it's necessary to read it.
Yes.
There was one question that 45 days were appropriate, or it might be better at 30 days rather than 45, but I'll leave that up to the will of the chair.
Okay, you got a question? Representative Reinders. Whoops. Send you over to the other side.
Thank you, President Cooper.
Yeah.
The only question I have as it relates to your amendment is, we can debate 30 or 45 days on the web, posted on the website. What I'm more concerned with is how long does it have to stay on the website?
Good point.
How long would you like for it to be on the website?
Well,
stay on the website.
It's according to how good or bad the rule change was.
It'd stay on the website until the rule was changed.
Rescinded would be my thought. And that's why Andrew's coming back up here.
Well,
no, you're talking about after approval?
Now, we post something that says you no longer have to do this. The truth of the matter is, I've got to assume it's kind of like someone showing you how to fix your transmission. Well, if I'm not going to need that for 3 years, what you told me 3 years ago doesn't matter. So if you took it down after 30 days or 60 days, it may not be relevant to me and what I need to know 6 months from now. Correct?
No, I kind of understand, but at some point...
I'm not going to need it until I need it.
Right, but once you need it, you don't need to know what it was before. You need to know what it is now. So that verbiage is inserted into the rules, the policies that are there. You don't want an infinite trail of changes when you need it.
Well,
you want
we
what
call
you
it
need when you need it.
archiving, and sometimes we do.
Wow.
For the purpose of saying you used to do it this way and you changed that without us knowing. But if we don't have that archive, we won't be able to know the benefit of why it was changed if we only found out about it for 30 days or something. That's the benefit of archiving.
Okay.
Right, Andrew.
Our policies and procedures are publicly accessible, and they're also date stamped on our website as well. So we would know when something was changed last, when it was received its most recent revision. Understanding what you're saying, we would make a notification that there has been a change, and then our policies and procedures do show a date of which they are.
Madam Chair, if it's appropriate, because I frankly don't know, but I'd like to amend the amendment to say after 45 days, comma, and stay posted for 6 months.
Is that
stay
a problem?
posted on the website for 6 months.
I'll accept it.
Yeah, I don't think it is a big issue, but I don't want 30 days to go, what happened to it? So.
Okay. Other comments from the committee? Okay, so everybody in favor of Representative Reiner's amendment to the amendment? Say aye.
Aye.
Anybody opposed? No? Okay. Then let's do the amendment. Well, let's do the bill first. Do I have a motion on the bill? Get that status. Okay. I have a motion and a second. Is there any further discussion on the main part of the bill? All right. We have an amendment to that part of the bill, and the amendment is SB 131 LC 213668.
So move.
Okay, have a motion and a second. Did I hear a second? Second. Any comment on the amendment as amended? No comment. Okay, everybody in favor of the amendment as amended, say aye. Aye. Anyone opposed, no. Okay, so now we're down to the House amendment, so the passage of Senate Bill 131 as amended by the House. And this will go out as a House substitute, right, Betsy? Because that's the way they go out of the House. So everyone, we're voting on Senate Bill 131 as amended by the House. Everyone in favor say aye. Aye. Everyone opposed, no. Okay, the ayes have it. Thank you very much.
Thank you, Madam
Senator.
Chair, and I'm going to see if Representative Rogers will carry this for me.
Thank you.
If indulge me 1 second. Representative Beverly, your kids here today were phenomenal. And you two, we'll see you out Veterans tomorrow. Thank you for your vote.
It's late to be schmoozing. You got your bill. Okay. All right. Let's. Okay, Senator Orrick. Here. Do you have anybody that wants to come up with you? Ma'am. Do you have anybody that you want to come with you?
Dr. Cohen is here.
Okay. And before Senator Orrick gets moving, Dr. Cohen, will you introduce yourself, since I know who you are after a long time friendship?
I'm Richard Cohen. I am a physician, orthopedic surgeon. I reside at 20 10th Street, Unit 1904, Atlanta, Georgia 30309.
And don't you still hold a position at Wellstar?
I do. I am the medical director for the ethics department, end of life department for Wellstar.
Thank you. Okay, Senator.
Thank you, Madam Chair, with your permission, and thanks for giving us time prior to the meeting to get a fuller understanding of what this Senate Bill 109 is attempting to do. The 109 is called the POLST bill. POLST means Physician Orders for Life-Sustaining Treatment. We are getting our arms around this issue for the simple fact of the matter that we want, as a state, to do everything we can to assure that people's end-of-life wishes are honored. Without some protection and some protocols and some things set in place in law, in addition to good, solid counseling and connecting with patients and their families, and educating the providers as well who treat patients that are facing a dire illness and end-of-life decisions. And we've been working as a state for a long time on this. A little bit of history. This bill will clarify and address legal issues in support of honoring patient preferences about medical treatment, if you want a kind of an overarching banner. And at the heart of it is the physician's order, the POLST. We have some significant history of working as a state to help Georgians indicate their treatment preferences and what they want and expect and need as they approach serious illness and the end of life. The Georgia Advanced Directive for Healthcare legislation was crafted in 2007. Some of us were here back then, some of us were not. But this incorporated earlier language about the living will and the durable power of attorney that we had done in the 90s. And the Advanced Directive for Healthcare provided individuals with a document, and you indicate your treatment preferences. You identify who you want to speak for them if you're not able to speak for yourself. The physician's order, the POLST, complements this Advanced Directive. And so the underlying language, you'll see a lot of language here that's already Georgia law. That's coming from the Advanced Directive legislation that was put in place 7, 8 years ago. The physician order takes the patient's treatment preferences and converts those into a medical order that's right there in the facility on site, travels with the patient, and can be used where the medical care is being provided. So your advance directive may be stuck in a Bible, may be in your son's sock drawer, or it may be that nobody can put their hands on it when the time comes that it's needed. The POLST makes every effort that it's signed by both the patient and their physician who attends, or by the patient's designated agent and the attending physician. And POLST forms are only completed for patients with serious illness or frailty, where their current health status indicates a need for a standing medical order. In the bill itself, it actually describes that last year of life, 365 days, when a physician, the attending physician, believes that the person is likely to pass away in the next year. You have before you a committee substitute because the Alzheimer's Association and the nursing homes pointed out they want and think it's important, and I agree with them, for you to be able to execute a POLST as well when you've got a diagnosis of dementia, impending Alzheimer's, progressive degenerative brain disease, anything that alters your ability to make decisions. So that's language, Madam Chair, that is reflected in this substitute, and it's very important. But the POLST form will indicate the patient's preferences, and our bill determines who must sign it. And I will point out to you that there are 22 states, including ours, that have POLST legislation on the books now. 17 states with programs, 27 are developing programs, and Dr. Cohen has worked a lot nationally, as well as been involved here a long time, as many of you know, on this POLST issue. And in 2010, the legislature authorized the Georgia Department of Health to create the POLST form. So this is not, we're not starting here from ground zero. We've been hard at work on this issue as a legislative body, and but there's been a lack of a comprehensive clarification of how the POLST intersects with the other Georgia laws that I've mentioned to you related to end-of-life care, and we've frankly not had widespread embracing as we want by some providers and some hospitals, out of an abundance of care, that we clarify the language on immunity. And on who do you consult with, and when does this come into effect, and does it travel from facility to facility? So that's why you have a bill before you today to get that accomplished. The POLST form's already up online and has been there for some 4 years now with the Department of Public Health, and anyone can pull that up, look at it, and use it. And of course, the vision is that you have a POLST form that's standard, so that if you're nursing here, if you're an emergency physician, if you're whatever department, whoever is engaging with that patient in a facility, be it a nursing home, hospice care, hospital, has that medical order that's signed and legally effective. I've worked and really appreciate all the help. We came out of the Senate with a unanimous vote on this bill. We've had input from the Medical Association, from the Hospital Association, from Emory and WellPoint being two of the lead hospitals on that, from the Nursing Home Association, the Georgia Hospice and Palliative Care, the Catholic Archdiocese, the Georgia Right to Life, the Alzheimer's Association, the Georgia Trial Lawyers, and the entire POLST Collaborative, which is about 30 organizations statewide. I can walk you through the bill, Madam Chair, as you wish, but I'll just do about 4 or 5 bullet points to highlight. One, this is effective with an incurable or irreversible condition, including a diagnosis of dementia or a diminished brain function. Transportability goes from facility to facility. It's valid as a consent, and the copy of it will be valid. A lot of times, many of us have had families relocate here when they're not able to take care of themselves, and they bring with them a POLST from another state. We clarified language here to say if it's substantially like ours and it's signed the way that we want it signed by the patient and the physician, that we can accept an out-of-state POLST. Up to now, without this bill, we would not be able to. And it clarifies that the immunity that is there that providers and hospitals and facilities want and helped us craft, and that this authorized person consents and works with the physician and the medical team, both in signing a post and seeing that it's in order and conveyed properly. And there are protections, language in here that are protections for relieving pain and treating pain. I'm going to stop talking, and I'm sure nobody disagrees with me. And Dr. Cohen can bring his comments, shed some light, and I'll be happy again to refer to any particular things in the bill, Madam Chair. And thank you for your guidance on helping us put
Dr.
this.
Cohen, thank you. Dr. Cohen, you want to make a brief statement, or you just want to answer questions?
I want to make a very brief addition. Number one, and I want to say it publicly, Senator Arrock has been a champion on this. She's really hung with us for several years in this process. And as I know you understand better than I, these processes do not come quickly, and they take champions, and I thank you for that. The only thing I want to add really to it is really two things. Most of us know what an advanced directive is, an advanced care plan. An advanced care plan expresses your wishes for how you choose to live and how you want to live at the end of your life. But it's not an active document. It's expressing your wishes. The PULST is a physician order, and because it's an order, it activates your wishes. And that's a key piece in the differential. So a person who's 45 and does an advanced directive doesn't need a PULST. But a person who's 50 and whose disease has progressed like kidney disease or something, and the physician feels you're probably in the last year of your life, or should you be in a persistent vegetative state, then a PULST would activate and become active. They're paralleling, they're coming together sequentially to try to assure that patients get the care they want. Unfortunately, when this all went through in 2010 in the bill and the in legislation, we didn't put a lot of the detail in. And the Georgia Hospital Association, to their credit, in the spring of 14 says, you know, there are some issues here that haven't been addressed. And that's really what this bill is trying to do. We have the form, and you should realize that it's a national form. What I mean by that is there's a National Pulse Paradigm Organization or task force. And they, in fact, endorse states, and what they do is try to create a uniform type document. So if you go to Tennessee, that's an endorsed state, and you use their form, it's going to look 96% like our form. And our form is going to look like the one in North Carolina. And the one in North Carolina is going to look like the one in Oregon. And the idea is that there should be this concept that can be carried from place to place across lines, because you just don't know, you know, it can be happen, and you could be transferred in the middle of your care because of something that gives you better care somewhere else, some other state, and this would go with you. And that's the purpose with it. I did take the liberty of putting 3 documents in your packet that may be helpful and of interest, and I thank you for your time.
That's great. I want to add one thing that we put in the Senate, and that's on line 156 through 159. This is language to make it crystal clear that this in no way does anything to change our language in Georgia law on prohibiting assisted suicide. And that's important. People need to know that and want to know that. And that language accomplishes that, paragraph F on line 5. Thank you, Madam Chair, committee members. Appreciate the
questions from the committee. Representative Beverly.
Thank you, Madam Chair, and thank you for bringing this important piece of legislation. I have a quick question. If someone has a living will, and at some point, you know, the person's at the end of stage, and maybe they're developing a little bit of dementia, and the patient and the doctor were to get together, a pulse was exercised, but the living will, the executor of the living will, did not agree with those 2 statements. Who would be the one?
If the patient is negotiating for oneself, that always takes priority. I understand what you're saying, that there's a living will that had someone else signing for the patient?
No, that the patient signed over in the living will. So, I mean, I just went through a situation that was very similar to this, and that's why I'm asking. I'm very sensitive to the fact that the patient may have a different set of priorities when it comes to end of life than what the living will, when they were in the right mind, that they executed. As you get closer to the end stage of life, oftentimes patients will change. They change their mind. And so in that event, if that event were to happen, what takes precedent at that particular point?
It is in this legislation.
Sure.
You will find the most current document.
Most current document.
The most current document by date is the one that is assumed to be the proper document to honor.
It's on lines, it's around the line 53 and 154.
Yeah.
Somewhere.
154.
But it's also in the law that decision-making capacity.
Right. Okay. All right. That's what I was getting at.
And that's on the in the definitions on page on line 17.
Okay.
That patient has to have the ability to understand and appreciate the nature and consequences of an order regarding end-of-life decisions. It's a good point. Thank you.
Representative Brenner.
That was my question.
Oh, okay, that was your question too? Other questions from the committee? Okay. Representative Jaspers.
Just a quick one. I assume this will be something that a hospital facility, whichever, would mandate. Is there anything here that mandates the patient to have to fill one of these out?
Absolutely not. This is totally voluntary.
Okay.
I mean, you do not need an advance directive. It's recommended you should have one. You do not need it, but there's nothing mandated in that form in any way.
Thank you, ma'am.
Thanks for the question.
Representative Rogers.
Thank you, Madam Chair. My question, Doctor, I have a health care directive now. This form that you're talking about is in addition to the health care directive. Is that what you're saying?
Yes, sir.
Okay. Second question. If there is a mistake by the doctor, by the facility, error in admission of any type, do I, the patient, of course I'm dying, I assume, but is there any recourse back to you or the facility?
The immunity pieces are exactly the same as they are in the advanced directive law that was passed in 2007. And we took that immunity piece out of 2007 to put into here, so they are both compatible, and they both provide the immunity. If a doctor in good faith honors your wishes, either in writing or any other form, then immunity is considered for the healthcare team accordingly. And one of the pieces that's important is that actually we had some legislation 2 years ago on this, but interestingly, it never ever said healthcare institution. So it said persons who, and it never really said healthcare providers or institutions. So the idea is that this should be complete, and it's a good intent. And my intent is to honor what you want and to make sure that of what it is. That requires a conversation. It's not just a document. I mean, if you have a pulse and you come into my office, or you come into the nursing home, or you come into the hospital in the emergency room. 6 o'clock this morning, I did a presentation to a group of ER doctors at Wellstar for the exact purpose of explaining what happens if a patient comes in with a pulse. How do you handle that? And the answer is a pulse is meant to give you a foundation, but it also requires you to have a conversation. You need to be clarifying that with the patient. You need to be confirming that, to your point, Representative, that this is your current thinking. Because fortunately, nobody here has done it, but if you're working with people in this area, you realize at 45 you have an idea about what life is like and what your qualities are and what you want. Well, now go ahead and become ill. And, okay, you start to think about it in a different manner. And then when you start to recognize that you really are at the end of your life, your value systems keep changing. These are not static issues. And that's why, quite honestly, there's nothing legislatively in the 2007, nor should there be, that says, well, if you write your advance directive in 2005, it's not current today. It is. But it's recommended that every 2-3 years, like you would have a regular financial will, Do you just put that in place and come back 20 years from now? Or no, every 3, 4, 5 years you revisit. And so this whole process should be revisited on a continual basis and updated. And that's how we, if you will, educate our physicians in the community. This is how we educate our nurses, our nurse practitioners and extenders as well. I mean, it needs to be an ongoing. The biggest problem we have is that we've become afraid to talk about death. We are afraid of it. If you go back 100 years, talking about death was a normal fact. We no longer think, and really the effort today nationally for those of us who are in this area is to try to go back and normalize. So what I want all my doctors to do is to say to their patients, Mrs. Jones, do you have allergies? Do you have high blood pressure, diabetes, tuberculosis? Do you have an advance directive? With no implication of prejudice, like I think you're going to die tomorrow. It's just a normal part of your health care package should be an advance directive. So that's where we're trying to go and what we're trying to accomplish. And this was another piece in that ability for us to honor and know what you want.
Follow up, Madam Chair. Doctor, when you do this form, you do it yourself, the medical doctor, correct?
Yes, sir.
Not your PA, not your advanced care nurse, or...
My advanced care nurse and my PA may start the conversation and may start the form, but I must personally sign that form. So I must...
So you're looking at me if I have 364 days to go, right?
Yes, sir.
Okay, thank you.
Good question.
Okay, Representative Pack.
Thank you, Madam Chair. Line 95, talking about recognition of the POLS forms from other states. Practically speaking, what does it mean to be substantially similar, and how would the Georgia practitioners know whether or not it's similar to other, let's say a North Carolina form, I don't know.
The implication, the real implication is signatures. The real point of the similarity is signature. So if North Carolina said the doctor could sign it and you didn't have to, or your health care advocate didn't have to, we wouldn't accept that in the state of Georgia. If, on the other hand, your doctor signed it and you signed it, or your health care advocate signed it, and it were substantially similar, and as I say, we're now probably at over 90% of the verbiage is the same state to state. The real issue is signature, which would be, if you would, provide authenticity.
Which leads me to my next point.
Well, could I just insert?
Sure.
There are 3 or 4 states that do not require that same kind of signatory, and they would be they would not be acceptable in Georgia. We want to be clear about that. That was brought up in our testimony in the House.
So are the practitioners trained on these type of things? I see somebody nodding their head back there. I don't know if that's correct or not. But.
The answer is multiple. The answer is it's one of the real conundrums. If you look at this panel here, look at the different ages we all are, and we've been educated differently. We come from different states. We have different religious backgrounds, and it's a very complex issue. And that's really what the work has been. I happen to be chairman of Georgia Health Decisions, and Georgia Health Decisions is a statewide agency. For the last 20 years, we've been working with hospitals and physicians to try to create a normal knowledge base so that everyone has the knowledge base. It's an ongoing process. And yes, if you have a physician who came out of medical school yesterday, he's well trained. If you have a physician who's 50, it takes time to engage him or her, and we're getting there. And most of these documents are being utilized by a narrow group of physicians: pulmonologists, intensive care doctors, cardiologists, nephrologists, and neurosurgeons and neurologists. They are much better trained and more comfortable. But one of the big problems is you're a primary physician. Just try starting the conversation. What is the icebreaker that gets you starting the conversation? So there's a great deal of training that's going on. The Institute of Medicine in September of this past year passed a The Institute of Medicine is part of the National Health Sciences Organization. It is the organization that said in 1999, we will change healthcare in America, you will be safer, and we will talk quality. And that has picked up and changed healthcare in 2005, 6, 7, and now. We all have safety and quality committees. We all have quality controls. We're all doing metrics to see where our quality, and to substantiate. Now the Institute of Medicine has come out and said it's time to start to work on end-of-life care. We are not providing adequate care across all spectrums. So you have a family, a person who becomes end of life, and you have a family who wants to provide care and keep them at home, but they're not resources. Or they're resources, but that particular community, you have the money, but you don't have the resource. So there are many, many issues, particularly the area of palliative care. And the growth of palliative care has been a major help in this whole area. So the Institute of Medicine is a document that's really sort of laid down a gauntlet. It's going to take 3 to 5 years for that to really start to take hold. This is all part of that. And that document mentions specifically medical orders and mentions pulse by name.
Okay. Just may I follow up with one last question? With the trend towards electronic records, requiring signatures and things like that seems to be kind of going backwards. There are other ways that perhaps you guys explored how to verify?
The answer to the question is twofold. Number one, if you fill out a pulse form today in your doctor's office, you can scan it into the electronic medical record, and hopefully you're on the same system as the hospital. So if you're Epic, an Epic system is a form of medical record, and you're a WellStar physician, you can scan it in. And if you don't do it there, but if you come to the hospital and you are at the end of your life, but you're in an acute phase, but we can get you through, and you go back home, and now you go to another hospital that has Epic, that pulse form sits within those documents. So to that extent, New York is starting what's called, and California are starting to do experimental work on what's called e-pulsed, an electronic pulsed. But it's fairly early in its infancy, and it is, it's going to take a little while for that to work. But with the federal government, you may be aware, but the federal government, CMS, and Medicare have made a very strong sentence that by 2018, all medical records are going to be electronic. Hospital, physician. So this is going to go right into that particular issue, and that's going to have to be resolved in that same manner.
Right. Representative Hawkins.
I want to commend you for bringing this before us, and also with the concept of ongoing review, because I will tell you I was startled earlier this year when I found out that to have a bed rail in an extended care facility, the patient must be able to ask for that bed rail. Now, right. My constituent's mother had Alzheimer's. They took the bed rail off the bed, and the next day she falls out and breaks a hip. So a directive would have really helped in that situation. So thank you.
Thank you.
Jeez. Okay. Are there any other questions? Okay. Seeing no other further questions, we have people that want to speak on this. Mike Griffin and Josh Dummins?
Edmonds.
What?
Edmonds.
Okay, Edmonds. Okay.
Thank you, Madam Chair and committee today. My name is Mike Griffin. I'm here representing Georgia Right to Life and also the Georgia Baptist Convention. Joshua Edmonds is here. He's our education director with Georgia Right to Life. And I'm also a pastor for 30 years. And I've had some great conversations with Senator Orrock, with Dr. Cohen. They're tremendously easy to work with on this issue. They've educated me. And Georgia Right to Life originally addressed 7 concerns in the Senate committee, and I would have to say that most of those were all taken care of, and we really appreciate that. And then working also in cooperation with other life organizations, we're able to offer an amendment that made it on the Senate floor, and our name was mentioned with others that were supporting the bill as it passed out. Now, there's been some changes today, and so I'm going to let Josh address one of those issues. But I just want to read just a general statement. I do have it available for the committee if they would like it. It won't take me just a minute. just to let you know where we stand on the issue of a pulse to start with, we're not comfortable with it. We do understand the advanced directives and the desire to be able to communicate that in post orders is genuine. We appreciate that. Our concern, among others, has to do with the food and hydration, and you can check that on the new order, and you can put that in your advanced directive. And our law that we passed a couple of years ago dealing with assisted suicide allows for certain types of medical decisions to be made like that in advanced directive. So there's a sense in which, and you can correct me if I'm wrong on this, Senator Orrock and Dr. Cohen, but until that's changed, there might not be much you can do about it anyway. We have tried to address some changes that we felt would just simply make this better. And like I said, a lot of those have been done. But anyway, we do want to thank Senator Orrock and her team advisors for spending many hours of time consumption on this particular issue. We did a lot of work on 109, and we appreciate the Senate for their help to ensure that no unintended consequences that would have negative effect upon Georgia's citizens at the end of life or unintentionally undermine our assisted suicide statute. And so that was our primary concern, and we have addressed those, or they have. At its core, however, the post-form movement has been suggested as the third path to assisted suicide by the euthanasia movement. It is the concern of the overwhelmingly majority of pro-life organizations around the country for the past 3 to 5 years that post-forms are biased towards non-treatment and to override a patient's carefully prepared advance directives. We know that the Catholic bishops of Wisconsin even released a statement in 2012 to avoid using forms such as post due to their serious threat that it poses to the dignity of human life. It is the position of Georgia Right to Life and the pro-life communities we represent that any legislation enabling or expanding post forms or their use can be dangerous. We believe that we've taken appropriate measures to mitigate some of those unintended damages that could be caused in our state. But we ask that these members of this committee may want to consider very carefully the implications that this may have or continue to have on the aging, the disabled, and the terminally ill citizens of Georgia. Be glad to answer any questions. We do have some additional changes that were not made in the Senate, and I'm going to let Josh be able to maybe comment on one change that was made here today that we just want to mention that we saw, if we might do that, Madam Chair.
We're all working off of LC 336170S.
Okay.
Yeah.
All right.
I'm sure you know that.
Josh, I'll let you mention.
Thank you, Madam Chair, members of the committee. It's my first time before you. I appreciate you for allowing your time to us today, and I know that many of us don't want this to go on any longer than it needs to, so we'll be as brief as possible. As Mike mentioned, we do have a handout that we prepared both with the statement Mike made as well as with some of the changes that we had noted in the Senate Health Committee that we wanted to provide for you if you wanted to look at it to see additionally what was on our list. Senator Orrock and Dr. Cohn worked very extensively with us in the Senate and made some great changes to this legislation with us. When we brought up some of our concerns in committee in the Senate, some of the members of the committee had some very insightful questions and some additional ideas that they brought up to us after our 2 times the 2 times we testified, 3 times that the committee met on this bill alone. So what we want to do is give the House Committee the liberty of hearing as well what we had to say in case there was additional ideas that your expertise and experience were able to bring to the table as well. And like mentioned, there's one change in this LC dealing with the execution of a post form when a patient's decision-making capability has been compromised. That was something that we brought up in the Senate committee as being a concern for us. what we were afraid of was a situation in which a patient had executed an advance directive that expressed one set of end-of-life care wishes, and then after that patient was incapacitated, their designee executing a pulse form on their behalf that might violate the express wishes they had before, and in that situation the patient was unable to advocate on their behalf for what they had expressed. And because, as we heard at the beginning of the testimony today, the most recently signed document is binding and supersedes the others, then the pulse form would supersede the advance directives that had been prepared prior to that point. And what we don't want to do is insinuate that, you know, every healthcare designee is out to get their patient that they're caring for. The doctors have malicious intent. We know that the intent of Senator Ork and Dr. Cohn are genuine. We appreciate our healthcare providers here in Georgia. We just wanted to raise some of the concerns we had to prevent some situation in which case that our citizens who were terminally ill or at the end of life might be taken advantage of when they're disabled or unable to vouch for themselves unintentionally through a pulse form being signed on their behalf. Additionally, we had some comments about, as Representative Pack had some questions about the out-of-state pulse forms coming in. We were happy with the changes that were made to that regarding it being substantially similar to a Georgia form to be accepted. One change we additionally asked for was that the pulse form coming from an out-of-state healthcare provider must be required to have the patient's signature on it, not their designee. When we consulted with Senator Ork and her team, they had mentioned that demographic was very low who might come in from out of state having a pulse form signed by a designee when the patient was incapacitated. So we wanted to just to be more safe than sorry and make sure that that potential mix-up in communication or the inability to track records accurately coming from across state lines, that patient was the one who signed that pulse form, and we're going to then accept it and execute it and implement it here in Georgia. And then one of the last changes we had was to the review of a pulsed form as it was in care transitions. That was a change that was made at our request that we appreciated. We also wanted to see about having some more clarification on when that pulse form is reviewed across care transitions and before implementation. I believe that the current LC does not require that form be reviewed before it's implemented. And as it was noted by the committee, a lot of things can change between when you first made that decision on your pulse form or on your advance directive and when you've actually reached the time for implementation of that care you've expressed. We believe that a safeguard of review between the attending physician and the patient or their designee would be a wise decision, so that there is the opportunity for that patient to reassess one final time before the decision to withdraw food or hydration or to opt out of CPR or antibiotics at that point is made, and that review would be listed in the text of the bill and then noted on the form as well. So those are some of the changes we had. We have this on a handout if the committee would like to take a look at it as well. And Mike and I would be more than happy to answer any questions you have.
I need one for you to answer, one for me.
Yes, ma'am. I'd be more than happy to.
We have very few days left in the session.
Yes, ma'am.
This bill came over to me last Friday, I think. No, it came before that. When did it come across? Because we've been talking about it, or you knew it was coming across and you knew it was going to be over here. And I have heard nothing from you. I don't believe my secretary has had a request for a meeting to discuss this with me. We are down to where we have almost no time to change things and have another meeting. You know, I don't appreciate that.
We apologize, Madam Chair.
I mean, because we are just flat out of time. So if this wasn't a tactic to try to kill the bill, you know, it's certainly not a good tactic to get any kind of changes that you wanted made.
Yes, ma'am. I think the intent was to educate the committee and allow the committee members to be aware of some of the additional concerns that were made in the Senate.
Well, then you don't understand how the legislative process works in the last 10 days of the session. And if you're going to lobby down here, you need to learn that, because we are down to the time where there's not a whole lot of chance to educate the committee in a committee meeting. And if you were going to do it, you needed to do it individually with a handout before this meeting so that we would have time, if the committee wanted any changes made, to really make them.
Madam Chair, we apologize for the inconvenience.
Madam
Questions
Chair,
from the
if I could
committee?
just point on page 3 that the review of the POLST form is recommended at care transitions, and such review should be specified on the form?
Yes, ma'am.
That was an effort to address exactly
What line
that
is that,
concern.
Senator?
That's line 63 and 64.
63 and 64.
Page 3.
Review of the form is recommended in care transition. Sounds like just what you said.
And that was what Dr. Burke suggested, that kind of wording, although he said it's absolutely the protocol currently, a doctor on our health committee. I would also add that Dr. Ben Watson, that you all have sent over to us from your committee, worked on this extensively, and he's a gerontologist and made great contributions to crafting the bill.
I think, Dr. Cohen, talking about the Alzheimer's part that we put on it, and talking about what would be put in place so you have the advance directive of what you think you want. I mean, if I have Alzheimer's, I don't want my life, and I just filled out an advance directory with a new will since Tom died, and I said certain things there, but like you said, that is not an active document. It's my wishes. If I have early onset Alzheimer's, where I know coming down the path I'm not going to be able to make decisions myself, but I am rational and my doctor says that I can make those decisions for myself. When it gets to where I can't make those decisions, wouldn't that be the document you would use? If I ended up in the hospital with less than...
Yes, that is the document we would use. And then there's the piece that has been added into this particular bill that's before you, and that piece in there talks about the fact that should you have dementia, that it would be appropriate to, even though, let's assume your dementia may take 5 years for that to unfortunately work through, that it would be appropriate to actually complete a POLST form while you were still cognitive. And that POLST form might be 3-5 years until that actually was activated. In most normal instances, if you were not in that situation, then you would wait until you were at that end of life, 1 year mark, if you would. So there's actually, that piece has actually been put into this bill to try to assist in that particular issue.
Okay, so that would be the one that would be honored at the time that I entered into the hospital, wherever it was in my last bit. Not something that somebody, my caretaker,
came out of a desk.
Or somebody else did for me at a later time, like my designee.
Well, your designee always has that power. The law of Georgia in 2007 said that the designee, the healthcare advocate, the authorized person, has the responsibility to honor your known wishes, and particularly states in the advance directive law. And then the Department of Human Services, when writing its initial rules and regs and then reinforced in 2012 with an update, says that both the healthcare team and the healthcare advocate or authorized person have a responsibility. Now, I'm not sure if you took it to court, but there is a moral, ethical responsibility to honor your known wishes. So if you had a POLST, those are your known wishes. Theoretically, your healthcare advocate, when you're unfortunately in a nursing home situation, could theoretically change that. But there is an imprimatur within the law that implies that if you had that form, that the healthcare team and the healthcare advocate should honor those wishes. They are known.
So it certainly speaks up for just the rare incidents when something happens. You should be very careful about who you choose to be your designee.
That's right.
Yes, ma'am.
And know where your documents are. And some states now, like Oregon, say that you put it in your front closet so that anybody coming to provide medical care knows where to look. That it's a standardized statewide thing. We don't have that here. We're not going to do that in this bill.
Okay. Questions for Mike or the other gentleman? None. Thank you. Okay.
Madam Chair, thank you for allowing us. We didn't mean to cause any trouble with you today. We know you have a very thorough committee and you do very good work and you make sure everything's covered. We were just adding additional information, and we thank you for your time today. We really appreciate you. Thank you.
Sheila Hummerstone.
Madam Chair, members of the committee, thank you for having me here today. My name is Sheila Humberstone. I'm with Stonebridge Consulting, in front of you today on behalf of the Alzheimer's Association Georgia chapter. We're now at every 67 seconds somebody's diagnosed with Alzheimer's. When I first started talking to you about Alzheimer's a few years ago, it was 71 seconds. We're now the 6th leading cause of death. We've moved up a notch from 7 to 6. While all the other causes of death are on the decline, Alzheimer's is on the rise, both in prevalence and in incidence. And we have no cures. We have no treatment. We have no options for that disease. We have some medications that mask the symptoms, but that's it. We've been working the last few years on this bill with Senator Orrock, with Representative Lindsay. I'm trying to think of all the people that worked on various iterations of this over time. And we are really looking forward to having a bill that helps POLST work, particularly in a hospital setting. We find these working really well in nursing home setting, and we think that this bill is a ginormous step to help us make sure that it works in a hospital setting. What we like especially about the POLST is that it moves the conversation from just being within your family to having a conversation, which is your sort of advanced directive. That's your conversation with you and your authorized representative. And with the POLST, you're then able to have that conversation with your physician, so you can get a better understanding of sort of timelines and what's going to happen. And I think that's a huge tool for families when they're making these decisions. I know I wish we did my mom's advanced directives back when she was first diagnosed without having any understanding of what the progression of the disease was ultimately going to look like. And so I think we would have had a more robust conversation had we known that. I want to again offer some special thanks to both chairs for accepting the amendments from the Alzheimer's Association. With Alzheimer's, we have no idea when you get diagnosed if it's going to be a year or 20 years, and so that's why the 365 days was a bit of a challenge for us. We advise people when they get diagnosed to come to our support groups. We also suggest that they get their legal and financial life in order while they can still have some self-determination. And so we recommend part of that is being your advanced directives, and certainly part of that is being your POLST. We have, like I said, find this working really well in nursing homes, and we're excited about being able to deploy these in other settings. Again, the 365 days, because when you're first diagnosed, that's when you can have the conversations and you can be a part of the decision making. Later on down in your diagnosis, you're relying on someone else to make those decisions for you. Just a couple other quick things. What I do like about the bill is that in a lot of the definitions, you'll see there are definitions that are cited in other places. So we're not creating new definitions of authorized persons. They're things that we've all worked together over time with advanced directives and other language to make sure that everybody's comfortable with it. Healthcare facility, healthcare providers. Again, you see lots of places in the bill where it just reiterates existing statutes. So I really think that there is nothing to be afraid of with this bill. I think it's a huge step forward for us. And then just in reference to the previous speaker, I do know that the Catholic Archdiocese in New York was sitting on the panel that helped create their POLST and has been working very hard and very well to make sure that it's implemented appropriately. So I'll answer any questions if you have any.
Questions for Ms. Humberstone?
Thank you for the time, and I urge your favorable consideration.
Thank you. Marcus Downs.
Madam Chair, members of the committee, my name is Marcus Downs. I'm with the Medical Association of Georgia. I want to commend Senator Orrock on this bill and everyone who's worked on it. MAG has had longstanding policy since 2007 on the POLST. We appreciate the fact that it's coordinated with an advanced directive and a power of attorney. We also established position in 2011 on end-of-life issues. I'll take any questions that you have, but want to offer our full support, and we ask for favorable consideration.
Any questions from the committee?
Thank you, ma'am.
I'll have to say that Representative Orrock and the hospital lawyers and the Hospital Association lawyers came and we went through the bill. They had some further changes that they wanted because you hear that it's working in a nursing home, and some of the hospitals would actually use the POLST form. Others had their own internal ways that they wanted to go about stuff, so they were hesitant to use the POLST form. So in this bill, you'll see that we put in where if they want to use their own forms, they can. We work through all of those suggestions by the hospital associations so they could adapt this to, their form of pulse so that they would honor the patient's wishes. And I appreciate the fact that they came and worked, and they worked over on the Senate side, as say the bill was vetted. Are there any other questions from the committee? Okay, what is the committee's pleasure? Have a recommend do pass. Wait a minute. Oh, your second. I didn't know you wanted to answer a question. And I have a do pass and a second. No one's come up with a last minute question. Okay. Okay. I think it's me. Okay. So we have a motion and a second. Everyone in favor of the passage of, I've lost the thing. The House substitute, or the substitute to the House substitute to Senate Bill 109, say aye. Aye. Anyone opposed, say no. Okay, the ayes have it. Thank you, Senator.
Thank you very much.
Dr. Cohen. Is that it? Yeah, are we through? We are adjourned. Thank you very much to the committees. Hope to see y'all later this afternoon.